At the onset, I'd like to thank Dr. Bansi Sabu for inviting this wonderful conference packed with current science, and it's my great pleasure to be here. So for the next 20 minutes or so, I'll be talking on a deep dive in lipoproteins in patients with diabetes. The conventional lipid profile is seen on the right side of the screen, and the numbers are there, and all of us are very familiar with this. The extended lipid profile, which we do on some occasion, the ApoA1, the B, the ApoE, BI-A1 ratio and LPA are on the other side of the screen. ApoB by ApoA1 emerged as the most powerful predictor of acute myocardial infarction in the INTERHEART study. These are ratios which we calculate. I think all of us are familiar with it. And these are special tests which we perform sometimes. Many times they are in the research lab, LDL particle size, LDL particle number, LPL-SA and others, and genetic testing in patients with FH. LDL particle size we usually do not estimate, but are on the screen. The large bind more than 21, and the small dense LDL is common in diabetics, less than 21 nanomoles. And these are the particle numbers. So diabetic dyslipidemia is high triglyceride, low HDL, high small dense LDL, postprandial lipemia, and LDL is mildly elevated. We are very much concerned with LDL cholesterol for a panoply of reasons. They are on the screen. It has a causal relationship with atherosclerosis. So the first issue is, are there any pitfalls in utilizing LDL cholesterol to assess the atherogenic risk, particularly in diabetic patients? Now these are lipid profile of two different patients, and you can see LDL is 130 in both these patients. So the question from the audience is, which one is more atherogenic? I think the answer should immediately come from the audience. Yes. So this is very important to remember, particularly when you are dealing diabetic patient with hypertriglyceridemia, because LDL only represents a mass of cholesterol in it. It does not give the number of particles. So if you have large buoyant LDL particles like this, you may have only 2 particles, LDL 130. On the other side, you have a lot of small dense LDL, you may have 4 or similar like this. So in patient with hypertriglyceridemia, you should not estimate the atherogenic risk by LDL. So the big message is, if LDL triglyceride is high, as commonly occurs in diabetics, it is associated with increased number of small dense LDL, and LDL cholesterol is not reliable to assess the atherogenic risk. Assess either non-HDL cholesterol or preferably ApoB. Indirect estimation is associated with fallacious results if triglycerides are more than 400, so usually we prefer direct LDL estimation. So why we are so much concerned about LDL? It not only assesses the atherogenic risk and helps in monitoring the effect of LDL lowering agents, but most important these days, it is a predictor of arrest of progression of atherosclerosis. It is a predictor of regression of atherosclerosis. So let's look at the data. So when we look at the LDL lowering trial during the 25 years of this century, what do we find? When we look at the issue, can we stabilize the plaque by LDL lowering? The answer is big yes. Statin therapy, all of us know there's data on it. Can we reduce the plaque buildup, which means can we arrest the progression of atherosclerosis? The answer is again yes, and data from the reverse trial very clearly shows. And this occurs when your LDL is less than 70, and that's why the Lipid Association recommends LDL less than 70 even for primary prevention, because you are at a safe level where atherosclerosis would not progress. Can we shrink the plaque, which means regression of atherosclerosis? The answer is a very big yes, data from the Glukov trial. And can we make the vessel, the plaque disappear from the vessel? Still an unresolved issue. Maybe in times to come, this may be possible. And this is a statement from none other but Dr. Patrick Saraz, interventional cardiologist leading ESC 2024. The pharmacological revascularization is going to increase, and the mechanical revascularization may diminish in times to come because the medical therapy is becoming so powerful. Cumulative exposure of LDL should not forget, and this is beautifully illustrated by FH. If you are a patient of homozygous FH, LDL is above 500 and you develop myocardial infarction at the age of 12.5 years. If you are heterozygous, LDL is usually above 200, you will develop myocardial infarction at the age of 35 years. And this is again a big statement. The risk of rupture rises exponentially above 5000 milligram, and when it reaches 7000 milligram years, usually you develop acute myocardial infarction. This is ESC 2024, and therefore we are running the race virtually to the bottom of LDL in the high risk and the very high risk patient. And as you can see, the cutoff points for LDL are being slashed down. Now this is another patient which was referred to us from government hospital. You can see the total cholesterol is 609 and LDL is 528. Moment your LDL cholesterol is above 500, this is homozygous familial hypercholesteremia. If it's above 200, this is heterozygous. And this is again from the Atherosclerosis Society, the simple chart, and you can see the features of homozygous. 17 years old, non-diabetic, non-hypertensive, non-smoker, father died at MI at 25 years, younger brother at 30 years, and so on. Another patient with FH. And we usually diagnose by this. When we try to look at what is the estimate of heterozygous FH in Indian patients, and one of the studies showed 15% in those who present as a premature coronary artery disease, not all premature, so less than 40 years. And for patients of H, we have this excellent upcoming modality to treat, the CRISPR Cas9 system. You will see the video. The guiding RNA guides the PCSK9 gene. Yes, you can see the Cas9 cuts it, and when this heals, the PCSK9 has lost its function. So this patient becomes loss of function mutation of PCSK9. In a single sitting, the LDL is slashed down to low levels for the rest of the life. Very, very exciting. The trial is still going, and the credit for this goes to these European ladies, and the hard-won trial is ongoing with WAVI 101. Some of the patient, the data is shown here. You can see the PCSK9 level with the higher dose slashed down by 89% and the LDL by 68%. So in times to come, this will be a one-time treatment for lowering LDL cholesterol. In those, it is markedly elevated as in patients with FH. The key message for this is all levels of LDL are atherogenic above 30. We are bound with an LDL level of 30, as you can see on the screen. And any level above 30 is atherogenic, and the Fourier trial beautifully showed it. If you lower LDL to 30, you get benefit, and all levels of LDL are safe above 30 because you are trying to lower it from a higher level to physiological. You are producing physiological lowering of LDL and not pathological. And to add to this, the data from the subgroup analysis of Fourier trial, LDL less than 10, incremental benefit without any side effects. So you should not be scared of lowering LDL to any level in a very high risk patients. These are the guidelines, recommendations for LDL cholesterol. Non-HDL is good because it gives you an idea about all the atherogenic proteins. ApoB is preferable if it is possible to get, because it directly gives you the number of atherogenic particles, and ApoB is not only a biomarker or risk factor, it's also a target. And this is the Manoria study which shows 1,75,000. The risk of myocardial infarction was best predicted by ApoB, followed by non-HDL and LDL cholesterol. And this again the cardiac study which shows that if there is concordance between, say, non-HDL cholesterol, LDL cholesterol, it may be approved. But if there is discordance between LDL cholesterol and non-HDL cholesterol, you should estimate ApoB. Again, meta-analysis of statin trials, which also favors ApoB, and this is again a meta-analysis, primary prevention and secondary prevention, and you can see ApoB is a better predictor compared to non-HDL or other lipoproteins. These are the targets for ApoB. You can see most of them less than 80 in high risk and less than 65 in the very high risk. We are amidst a golden era for lipid management. We have three agents for oral agents: statins, high intensity, 50%, ezetimibe, another 15%, and bempedoic acid, maybe another 15%. So we can lower up to 75 to 80%, and we have PCSK9 and inhibitors and inclisiran. What about triglycerides? This is the classification of triglycerides, you can see. So now let's look at a case. This is a 28 years old male, acute pain in the upper abdomen, vomiting, sweating of 3 hours duration, some minor ST changes, and was referred to as a suspected case of myocardial infarction inferior. The blood was sent for cardiac troponin and other biochemical investigations, and the pathologist technician came to us that this is the serum. So the diagnosis of this case is triglyceride-induced pancreatitis. And we look at the triglyceride level over 6,000. So this is genetic hypertriglyceridemia, and lipoprotein lipase deficiency, ApoC2 deficiency has to be estimated. CT showed pancreatitis, lipase, amylase were elevated, diagnosis was hypertriglyceridemia induced acute pancreatitis. On taking his two similar episodes, but were not diagnosed. Treatment is usually lowering triglyceride with various drugs, but now we are again in a golden era that we have this new drug, olezarsen, which is approved in Feb 2025, and the balance trial, as you can see in the middle, lowers triglyceride by 43.5. So we have a lot of drugs now to lower triglyceride by multiple mechanisms. This is an antisense to ApoC3 mRNA. So you have the conventional drugs and this new drug. So triglyceride even in patients with familial hypercholesterolemia can be reduced to substantial levels. Triglycerides and ASCVD is a little tricky problem. The diabetologists very strongly feel that increased triglycerides are associated with atherosclerosis, and if you lower triglyceride, there may be reduction in cardiovascular events. They may be right, but let's see, is there an evidence that lowering triglycerides reduces atherosclerotic cardiovascular events? There is no doubt that increased triglycerides are associated with increased atherosclerotic cardiovascular events, more all-cause mortality, more cardiovascular mortality, more thrombotic lesions. No doubt, all trials of statins, there is residual risk, and one of the important factors is raised triglycerides. And here you can see more triglycerides, more cardiovascular mortality, and more all-cause mortality. Loss of function mutation, ApoC3, triglyceride is very low, less cardiovascular events. But the big issue arises, which we are not yet clear, when we lower triglycerides, does the atherosclerotic cardiovascular events decrease? So if you look at the green one, the trials of fibrate without baseline statin therapy, there is decrease in the cardiovascular events, but that is not the way to go. At the present state of time, you have to be on a high intensity statin or on a maximum tolerated statin. So when we look at the ACCORD trial, the trial was negative, prominent trial, the trial was negative. The diabetologists often show this meta-analysis that in a subgroup of patients with triglyceride 204 and HDL less than, there was a benefit. But if you look at this PA hit HHS, the BIP trial had no statins, and field trial statins were not at baseline. So that is not appropriate. And this hypothesis was tested in the prominent trial. You can see same subset, but the trial failed to show. So at the moment, we do not have any evidence that although increased triglycerides is associated with increased cardiovascular events, but decreasing triglycerides do not decrease cardiovascular events. Niacin, both the trials were negative, and EPA, any trial which utilized only EPA was positive. The reduces trial was the representative, and you can see 8,000 patients, established CVD, diabetics with risk factors, LDL 41-200 and high triglyceride 135-49. There was a statistically significant reduction in the primary ischemic endpoint and also in the secondary. And those who were proponent of triglyceride felt very happy that now this is the trial that you lower triglycerides, the cardiovascular event. But when subgroup analysis was done, you can see triglycerides less than 150, more than 150, no difference. Secondary endpoint, benefit was more in triglyceride less than 150, clearly indicating that the mechanism of reduction in cardiovascular event was not related to lowering of triglycerides. In fact, REDUCE trial was not a triglyceride lowering trial, it was a vascular trial. And this again is a Quebec study. If you have a basal risk, if your triglycerides are elevated and ApoB is normal, the risk does not increase. The moment you have hyper ApoB, the risk increases. And one of the reasons why this happens is that it is ApoB which enters the vessel wall, and at whatever levels of triglyceride you see hypertriglyceridemia, the contribution of the chylomicron remnant or VLDL remnant is only 10% or 15%. That is the reason why they do not majorly contribute to regression. So what does ADA 2025? Triglyceride more than 100. Look, treat for pancreatitis, prevent pancreatitis, which is easy if you treat in time. 150 to 499, lifestyle measures and treat the secondary cause. This is a lifestyle problem. But you have an ASCVD with risk factors, LDL to target, like the reduced trial, use EPA, fibrates and niacins are not recommended, they are just cosmetic therapies. Remnant cholesterol, total cholesterol minus HDL cholesterol minus LDL cholesterol. There's a lot of hype in remnant cholesterol. There's data to support it, decrease MI, decrease PAD and ischemic stroke, but none of the trials has shown that if you decrease remnant cholesterol, it decreases events. So not in the guidelines as yet. Lipoprotein A, very important, associated with high atherogenic risk and is unique that is two ApoB, one ApoB on the LDL and ApoA is attached to the LDL by, and this is because it's pro-atherogenic, pro-thrombotic, pro-inflammatory. And in the context of diabetes, there's inverse relationship between the risk of diabetes and LPA. So if you have more LPA, less diabetes. So this is individual again, 40 years old male, physically active, non-obese, no past history of diabetes, hypertension, total cholesterol 184, LDL 118, HDL 58 and TG. His physician told you the LDL is 118, the European Society guideline reference 1 says you are a low risk. But next week he develops acute myocardial infarction, RCA angioplasty is done. The reason is this strong family history, you must suspect LPA, and this must have been estimated, came out to 107. And the big message for is LPAs, when you estimate LDL cholesterol, it gives you a combination of level of LPA and LDL. So if LPA is substantially elevated, the risk prediction by LDL becomes fallacious. Statins will not lower LDL to your expectation. These are the normal levels, no approved treatment at the moment, and LPA-induced cardiovascular disease is now considered to be a slow death warrant because malignant progression, disease occurs early, but the pelacarsen in the Horizon trial is being evaluated. The trial is going to be released early, and if this comes out to be positive, this would emerge as a transformational therapy for LP-induced cardiovascular disease, and there may be a new dawn of LPA therapeutics. Besides this antisense to ApoA, pelacarsen, 3 small interfering RNA are being tried. The olpasiran in the OCEAN trial, the lepodisiran in the ACCLAIM trial, and zersiran in the alpacard trial, and one oral agent is also being tried. You can see Povoplin, the Kraken trial was released in AHA 2024. Aspirin we prescribe to patients with irregular LV. Usually we do not prescribe aspirin for primary prevention, but here the results have shown because LPA is thrombogenic also because it is homology to plasminogen. So in summary, what do we have? When we look at the evolution of lipid guidelines during the last 37 years, from 1988 when ATP came into existence to 2025, what do we get? LDL continues to remain the primary target. LDL, LDL, LDL. Non-HDL, important, is a co-primary target. HDL is a fallen angel. All trials of HDL elevation, pharmacological elevation on top of statins has been flop trials. As you can see on it, triglyceride, increased levels of triglycerides are associated with increased cardiovascular events and mortality, but lowering of triglycerides have not yet shown to decrease cardiovascular events. So still under evaluation. LPA, there's no evidence-based target at the moment, but the Horizon trial, when it is released, we will be having some data. So thank you very much for your kind attention.